Good evening, everyone. Welcome to our sixth Blue Health virtual seminar. To give you a little introduction about Blue Health virtual seminar, Blue Health virtual seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this program is brought to you by, this platform is brought to you by, as always, Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. We aim to be an influential healthcare leaders in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Adam Getachew. I'm the co-founder and CTO of Blue Health Ethiopia. And we are honored to have Dr. Semir Sultan here with us to give us an update on postpartum hemorrhage. So this is a little introduction. Dr. Semir, the floor is yours.
Okay, thank you. I would like to thank and congratulate the team for coordinating this webinar, and also good evening and welcome, dear friends, to this interesting topic, updates in postpartum hemorrhage. So I will directly go to my presentation. And I'm not usually a big fan of long lectures in the seminars, so I will try to keep the presentation or present it in a very short minute, and then we will have a time for discussion and question and answer sessions. So generally, obstetric hemorrhage, including antepartum hemorrhage and postpartum hemorrhage, are a major cause for maternal deaths worldwide. So by the end of these presentations, participants, you will be able to identify what are the challenges in PPH management. And the tranexamic acid is the new hope. And we will see later on why I say this. And what will be the current protocols in prevention and management of postpartum hemorrhage. So I just found this quote on the internet, and it says that in one's life there are always two choices. One can stay single and be miserable, or you can choose to get married and wish you were dead. So this might be a joke for us living in the 21st century, but before the beginning of modern obstetrics, maternal mortality is close to 1%, which means 1 in every 100 women after getting pregnancy will die of pregnancy complication. Yeah. So thanks to modern medicine, maternal mortality has been significantly reduced, but still we are far away from reaching our goal in reducing maternal mortality. Most of these maternal mortalities worldwide occurs because of obstetric hemorrhage. So nearly 1/4 of all maternal deaths are due to postpartum hemorrhage. And what is interesting is that most of postpartum hemorrhage related deaths are preventable. And if we diagnose postpartum hemorrhage early and treat appropriately, again, we can save a lot of maternal deaths from happening. So why the challenge? Why are we not able to reduce maternal mortality significantly? One of the problems is in the definition of postpartum hemorrhage. I hope you are all well know the definition of maternal hemorrhage, the traditional definition, which says that if a woman bleeds 500 ml following vaginal delivery or 1000 ml following cesarean delivery, okay, is defined as postpartum hemorrhage. The problem with this definition is that accurately estimating the blood loss is clinically very difficult and challenging. So different institutions and the societies across the world has also come up with a different definitions, like a constant trickling of blood after delivery, or a blood loss sufficient to cause hemodynamic instability in a woman. Still, these definitions, okay, they lack, they are not clinical, because at the time the woman is hemodynamically unstable, she has lost significant amount of blood. So still the definition of PPH is a problem for the global world. So I like to say that PPH is just a definition, not a disease or a diagnosis. We have to remember this. Okay? So we should not say that the woman, she has bled less than 500 ml, so she's not in PPH, or she has not bled less than, or she is bleeding less than 1,000, and this is not PPH. We cannot categorize a woman as such, because absolute number will not define a woman. Example, women with anemia or preeclampsia, they can develop hemodynamic instability after losing a small amount of blood. So the definition is one that's challenging, and currently I would say that PPH is best defined and diagnosed clinically. If the woman is symptomatic, if she's complaining of lightheadedness, dizziness, or there are signs of hypovolemias like tachycardia, hypotension, we can diagnose PPH clinically. Postpartum hemorrhage, broadly classified into primary, that occurs within 24 hours after delivery, or secondary, which occurs after 24 hours of delivery. Today's topic, I would like to focus on primary PPH, because this is the majority of the cases that causes the maternal death. What is our second challenge in management of PPH? Most of the women, after having postpartum hemorrhage, are inadequately resuscitated. What is interesting is that in pregnant ladies after delivery, the amount of blood loss can correlate with signs and symptoms the woman manifests. So in class 1 hemorrhage, after a woman has lost from 500 to 1,000 ml of blood, we can say the blood pressure is normal. The pulse rate is normal. Yeah, the only thing that she may complain will be dizziness or palpitation. In class 2, when the bleeding is above 1,000 but below 1,500, the woman will become tachycardic, more than 100 the pulse rate. But the blood pressure is still within the normal range. In class 3, when the woman loses more than 1,500 ml of blood, up to 2,000 liters, now there will be hypotension. By the time the woman develops hypotension, okay, in class 3 and in class 4, the resuscitation will require transfusion of blood and blood products. For class 1 hemorrhage, transfusion with normal saline or ringer lactate will suffice in most cases, but the woman has to be resuscitated with adequate volume of normal saline or ringer lactate. So what are the risk factors for postpartum hemorrhage? The strongest risk factor is previous history of postpartum hemorrhage. Other risk factors include women with preeclampsia, women who are anemic because already they have compromised cardiovascular system, women with multiple gestation or previous cesarean section. Okay? And all the others are also other risk factors. Why are we interested in identifying risk factor in a laboring woman? Because there will be a change in the management for this particular woman. We all know that active management of third stage of labor is employed for all laboring women. because we know that all laboring women are at risk for developing postpartum hemorrhage. There is no way of knowing, identifying which woman will develop or which one will not develop postpartum hemorrhage. So any laboring woman is at risk of developing postpartum hemorrhage. But if there is additional risk factor which categorize a woman for high risk, okay, please consider, okay, adding this management, okay, in addition to the standard protocol. Have cross-match blood ready, put the woman in oxytocin infusion for 1 up to 2 hours after delivery, or give ergometry injection, or give her misoprostol from 200 up to 400 micrograms. Here, I would like to emphasize that giving a higher dose of misoprostol, more than 400 milligrams, as a prophylaxis for PPH is not beneficial. Rather, there could be side effects, okay, like fever, pyrexia, upper GI bleeding, and even documented maternal deaths. So, for prevention of PPH, the misoprostol dose should be up to 400 micrograms. Okay, the notion higher dose will be better does not work here. We all know the causes for PPH, the major causes for postpartum hemorrhage are remembered by the 4 T's. Yeah, atony, uterine atony being the most common one, followed by trauma to the vagina, cervix, or uterus, tissues left like placentas, liver placenta, Roche placentas, or DIC or thrombin. So uterine atony is the most common. Almost 19% of all postpartum hemorrhage are because of uterine atony. Here the uterus will be boggy. Yeah, there will be excessive or bright red bleeding or clot upon massaging the uterus. Despite a well-contracted uterus, if bleeding persists, we will consider laceration to be the next differential diagnosis. So always at the time of delivery, please look for the placentas and the membrane that it is complete. When we come to coagulation defect, DIC, especially in severe postpartum hemorrhage, all women will end up developing DIC if they are not well managed. So, management of postpartum hemorrhage. The first one is always shout for help, because truly postpartum hemorrhage is a team approach. That is why international societies and organizations currently recommend for having a drill for postpartum hemorrhage in health facilities. This drill should be conducted every 3 months. I think this is the practice we need to start in our country, having a drill for postpartum hemorrhage. Because when postpartum hemorrhage occurs in a setup which is not well organized, then we will have a chaos, yeah, where we will be disorganized in managing the woman, and the time is the essence here. Time is vital, time is crucial. Every minute is important for the woman's life. Okay? So have a drill for PPH, I would strongly recommend, so that at the time a woman develops PPH, we are well organized in managing the woman. What is the standard way of managing the woman? We call it the initial resuscitation for all cases of PPH includes shouting for help, ensuring intravenous access, at least 2 for transfusion of fluid, blood, medication to draw blood for laboratories. I say that fluid resuscitation and transfusion has to be adequate. Give oxygen administration and maintain the saturation above 95%. We need to take vital signs frequently, the pulse rate, the blood pressure, monitor the urine output. This is the practice that we were doing for the past decades. What is now to this management? Is there a new update in the initial resuscitation of women who develop postpartum hemorrhage? So of course, there is a new update. In 2021, the obstetric management protocol has been updated. And here, okay, I would like to go through the algorithm and we will see what is new to this one. Okay. So once we have diagnosed a woman having a PPH clinically by either hypotension, tachycardia, or the amount of blood loss, our general management will be for evaluating ABC, securing IV line, give oxygen by mask, check if the uterus is well contracted, if not massage, catheterize the bladder, and monitor for vital signs. Okay. If placenta is delivered, I say check whether it is complete or not. If the placenta is complete, we will continue with our fundal massage, give oxytocin, which is the golden drug, the golden uterotonic agent in PPH management. And now the addition or the current update is to give tranexamic acid 1 gram in 100 ml IV over 10 minutes with 3 hours of birth. Tranexamic acid is given for all women who develop PPH, regardless of the cause for PPH, whether it is atony, whether it is trauma, whether it is retained placenta, whether it is DIC, you have to give tranexamic acid. Tranexamic acid is currently part of the initial resuscitation for women who develop postpartum hemorrhage. This is well documented and stated in our protocol. And also in World Health Organization in 2017 guideline for management of PPH, they have stressed the importance of tranexamic acid, which I will be mentioning it in the later slides. So the algorithm will continue, right? If the uterus is contracted but is still bleeding, we have to explore for trauma. If we identify vaginal or cervical laceration, we have to repair. For cervical lacerations with extension to the uterus, please refer to hospital level where there will be a gynecologist available. If you consider the causes to be uterine atony, we will start with oxytocin as the first line drug. If it is not responding to oxytocin, the second line drug is ergometry. If the uterus is still not responding to ergometry, then the third line drug will be misoprostol. Here the take-home message is avoid giving misoprostol as the initial drug with oxytocin. There is a randomized control trial showing that treating women with oxytocin alone compared with oxytocin with misoprostol doesn't show any benefit, any additional advantage of adding misoprostol to the management standard. Rather, there were side effects documented in that group. So the standard, the golden drug is to give oxytocin. If only oxytocin is not available or the uterus is not responding to oxytocin, then you will add ergometry. If it's not responding to ergometry, then you will give misoprostol up to 800 microgram. Here the dose is up to 800 micrograms, recommended by World Health Organization. But for prevention of postpartum hemorrhage at high risk, 400 microgram will be enough. Let's see what is the updated World Health Organization's recommendation on the use of tranexamic acid for treatment of postpartum hemorrhage. Tranexamic acid is a synthetic lysine amino acid, and it works by blocking the receptor for plasminogen activator. So the effect is it will reduce bleeding by inhibiting breaking down of fibrinogen in the fibrin clot. Now, World Health Organization has listed tranexamic acid as an essential drug. And currently in our country, in most hospitals, tranexamic acid is available in IV forms and PO tablet forms. And the World Health Organization has updated the recommendation on tranexamic acid for PPH treatment, and it has changed its guideline for PPH management, published in 2012. Now they have produced another guideline in 2017 because they found tranexamic acid to be very useful in managing postpartum hemorrhage. The recommendation came from two large multicentric randomized trials, especially the woman trial, is a very large trial done in middle and low-income countries involving more than 20,000 women with severe PPH. The addition of tranexamic acid within 3 hours of delivery has significantly reduced maternal mortality. It was able to prevent the maternal deaths of one woman, okay, in 5, 20% reduction. So the addition of tranexamic acid in the management of PPH will prevent the addition of the deaths of one mother, okay, an additional one mother in 5 maternal deaths. This is a strong recommendation with moderate quality of evidence. Despite the recommendations by World Health Organization and also our protocol, when we do maternal death increase or an analysis, we found that most women have not received tranexamic acid. This could be maybe a gap in the knowledge or drug availability, but now the drug is available in most hospitals. I would recommend all health professionals working in the delivery or labor ward to consider tranexamic acid used in management of PPH within 3 hours of delivery or birth. The dose is 1 gram intravenously, okay, and you should infuse it in a slow 1 ml per minute. Bolus injection of tranexamic acid can cause maternal hypotension, so avoid bolus injection. Please label the vial of tranexamic acid because there is similarity with lidocaine. So try to label the vials or read carefully before giving the woman tranexamic acid because of the similarities in the shape of the bottles of tranexamic acids. Second dose of tranexamic acid can be considered if bleeding continues after 30 minutes or if bleeding starts within 24 hours of completing the first dose. Tranexamic acid should be given within 3 hours. So 3-hour window is the time of birth. If unknown, use your best estimate of time. After 3 hours of birth, there is no benefit of tranexamic acid. That is why we say within 3 hours of birth. So tranexamic acid should be part of the standard postpartum hemorrhage treatment package. Use tranexamic acid in all cases of PPH, regardless of the cause. Avoid using tranexamic acid in a woman with a clear contraindication to antifibrotic therapies, like women with history of deep venous thrombosis or pulmonary embolism. And tranexamic acid is very safe. In this large randomized controlled trial, there was no major adverse outcome that occurred by addition of tranexamic acid to the PPH management standard. Again, we should use the intravenous use of tranexamic acid only because for the other route or doses, we don't have strong evidence so far. There are studies conducted, ongoing studies, to see if other routes of tranexamic acids can be used in management of postpartum hemorrhage. And even in April of this year, we are expecting Women 2 trial. Women 2 trial is a multicenter trial, then again in low and middle income country, to see if transamic acid could be used in prophylaxis as a prophylaxis in postpartum hemorrhage as a preventive therapy. So that study will be released in April of 2022, this year, and then maybe we will update our management. However, till now, transamic acid is going to be used for treatment of postpartum hemorrhage, not as a prophylaxis. So transamic acid is a life-saving intervention. It should be readily available wherever emergency obstetric care is provided. Of course, there are a lot of updates in postpartum hemorrhage. One update will be the use of uterine tamponates, which have shown to decrease operative interventions by up to 90%. However, the use of uterine tamponade will require a training, and the Minister of Health is working with the Ethiopian Society of Obstetrics and Gynecology to provide this training to general practitioners working in the hospitals, so that mothers can also use these new innovations. Maybe in the future, we will have heat-stable oxytocin for treatment of postpartum hemorrhage. We will have a negative intrauterine suction devices for management of postpartum hemorrhage until these researches are conducted and available to the general population. We will be using oxytocin, transamic acids as the standard treatment, and the addition of ergometry and the misoprostol if bleeding does not respond to misoprostol. Bleeding does not respond to oxytocin and transamic. So that the updated whole recommendation is accessible online using these links. I will strongly recommend our physicians, my colleagues, to read on the woman trial, a very interesting research. And I would like to thank you, and this is my presentation. And if you have any questions, comment, or suggestion, I think we can go through the discussion part. Thank you.
Okay, thank you so much, Dr. Semir, for your presentation. So I think we have one question in the Q&A section of the Zoom, so you can answer that, while participants can post your questions in the question and answer part of the Zoom, so Dr. Semir can answer it now.
Okay, so in secondary, the question is why we say secondary PPH up to 12 weeks as purpurium lasts up to 6 weeks. I think this question is a relevant question. So again, the definition of purpurium up to 6 weeks or 12 weeks is again controversial. Some societies define purpurium up to 6 weeks, and some societies define the purpurium period up to 12 weeks. For most women, uterine evolution will be completed by the 6 weeks, but for the rest, it may take up to 12 weeks. That is why the duration is extended up to 12 weeks. So it depends how you define purpurium. Is this 6 weeks or 12 weeks? So according to our protocol in our country, purpurium is defined up to 12 weeks. That is why we say secondary PPH for after 24-hour delivery to 12 weeks. I hope that answers the question. So the second question is transamic acid available in Ethiopia? both the tablet form and IV forms are available. The third question is, oxytocin only available in hospital or place where refrigerator are available. What in health center with no refrigerator? As I already mentioned, if oxytocin is not available, then misoprostol can be used as for management of postpartum hemorrhage. But if oxytocin is available, just use oxytocin, which is a gold standard uterotonic agent, and do not add misoprostol on this management unless the uterus is non-responsive. Okay, so the other questions are, what is the dose of ergometry and oxytocin? I hope you will find this. I will share the slide, and on the slide, the doses are mentioned. But just to mention, ergometry 0.2 or 1 vial of ergometry start. For oxytocin, 20 international unit in 1 liter of normal saline, and you will start the drop by 16 drops per minute until the bleeding arrests. When the bleeding stops, you will continue the drop at 40 drops per minute. So you will add 20 international units of oxytocin in 1 liter of normal saline, start the drop by 16 drops per minute, and continue till the bleeding stops. Once the bleeding stops, the maintenance drop will be 40 drops per minute. So management of retained placenta. So management of retained placenta is manual removal of the placenta. It is strongly recommended that you will give strong analgesic and antibiotic before you remove the placenta, and it is better than in the operation theater. But in some circumstances, you may do it in the labor ward. So how do we give tranexamic acid in tablet forms? I mean, in what gram are available in tablet forms, and when do we use the tablet forms? As already mentioned, for management of PPH, it is only the IV form of tranexamic acid that is recommended. Other routes, like tablets, are not recommended in the management of PPH, as there is no evidence showing that they are beneficial. Of course, they are ongoing researches, but still we have to wait for recommendations from the World Health Organizations. Otherwise, currently, the IV form is the standard in the management. As tranexamic acid uses for management of PPH, why we didn't use it as active management of third stage of labor? Again, the same reason. Women trial 1 has shown the benefit of tranexamic acid for treatment of postpartum hemorrhage. There is a large now randomized control trial called Women Trial 2 that is evaluating the benefit of tranexamic acid as a prophylaxis for postpartum hemorrhage or part of active management of third stage of labor. This study hopefully will be published in April of this year, and we have to wait for this recommendation. Till then, tranexamic acid is just used for management of postpartum hemorrhage. Is there a place of using tranexamic acid for, I think it's the same as an answer. For high-risk patients, tranexamic acid is not used for prevention because we don't have any evidence for it. For high-risk patients, the recommended is either to continue oxytocin infusion or ergometry or misoprostol for 100 microgram.
Thank you, doctor. I think I have to stop you. I'm really sorry.
Okay.
Thank you so much for your patience for the presentation and also for the Q&A session. I'm sorry, guys. We couldn't answer all of the questions because we have a limited amount of time. Thank you, Doc.
Thank you for the invitation, and thank you, the audiences, for your attention. and also for the questions. I hope the session was interesting, and of course, I hope you will change your clinical practice by adding tranexamic acid for management of postpartum hemorrhage.